This week on the BackTable podcast.
Why is low grade the way it is? Why is high grade the way it is? Why does some low grade grow to 5 centimeters and not seed the bladder all over? And then some of it is tiny little 5 millimeters all over. So what is some of the kind of molecular basis of why that's happening? And can that help guide us further with treatments? Right now, if you even think about the way we talk about, grade, it's like low grade or high grade. We don't have a detailed definition. I tell people, we put this in 2 buckets. And so I think that that's understanding more about why things are the way they are from a genetic and a molecular component, and then trying to see what their overall disease trajectory. I think a lot of what we end up doing is kind of buying time to see how things are going to play out. And then we start kind of layering on our interventions and see how people respond.
My name is Ruchika Talwar. I'm a urologic oncologist at Vanderbilt in Nashville, Tennessee. Today, I'm thrilled to be joined by Dr. Lindsey Herrel. She is one of my, I'd say, mentors and a guiding light for many of us in urology. And she'll be chatting with us today more in the intermediate risk bladder cancer space, but we're going to be digging into where we are today, what new trials are illuminating for us, and where the future is going. Dr. Herrel, why don't you take a second to tell the audience about yourself?
Super happy to be here. Thank you for inviting me. Like Ruchi said, my name is Lindsey Herrel. I am an associate professor at the University of Michigan. I've been on faculty for about 8 years. Time flies for all those people who are new to practice. And primarily focus my practice on bladder cancer work, so cystectomies, and do a high volume of non-muscle invasive bladder cancer as well.
Awesome. Well, again, we're just thrilled to have you and can't wait to pick your brain about this challenging area. Intermediate risk bladder cancer is one of those. I was speaking to another guest about it recently, and I said it's almost like a stepchild. It's not low risk. It's not high risk. There's still a lot of confusion. Patients are confused. Clinicians get confused as to what they should do, particularly in the era of shortages of things like BCG. So I just want to ask first, what are your overall thoughts on the intermediate risk space, and what are some challenges that you think we should all be aware of as we see these patients?
Yeah, I think, to start with, it's helpful to kind of define who these patients that are intermediate risk are. So we have kind of the low-grade subcategory of intermediate risk, so multifocal, larger tumors greater than 3 centimeters, which most of our guidelines agree on, those patients being intermediate risk, or recurrent disease. And, recurrent low-grade bladder cancer is kind of the bane of, I think, all of our existences. We're happy when we can wipe it out on the first go-round, but when it starts coming back, it can be very nuisance disease. The other component of intermediate risk disease is folks who have high-grade, smaller tumors. So AUA defines it as less than 3 centimeters. So those first-time, high-grade, non-invasive PTA disease. And so that's really that intermediate risk category. And what makes them frustrating is they're not super likely to develop progressive disease. So they have less than 5% chance of progressing, but they are very frequently patients who have recurrent disease. So about 50 to 70% of them will recur. So that's what makes them frustrating to care for, is you're trying to strike this balance of not overdoing care. And, I tell all these patients, I'm going to see you a lot over the next few years between cystoscopies and intravesical treatments, and we're going to get to know each other very well. So, but also trying to make sure you don't let something get out of hand that was curable to start with.
Yeah, and I think that's really my biggest challenge when I see these patients, is walking that fine line between overdoing it and underdoing it. So I'm curious, let's say we have a patient who comes in with a small high-grade tumor. They meet the intermediate risk categorization. What's your approach? How does that discussion look?
Yeah, so I, tell a lot of these folks up front that this is a disease that looks like it or tends to recur. So I try to set that expectation early, because I think people are often surprised when they hear a number as high as 50 to 70% of these folks will recur. Patients need to know that up front, need to know why they're getting frequent cystoscopies, why we treat them. And that's to prevent a recurrence, really. And so understanding that, sometimes I use an analogy of these are kind of weeds in a lawn, particularly with low-grade disease. And so you have, weeds that are popping up within your lawn, and you can do one of two things. You can go pull weeds by hand. That's a TURBT to get rid of the disease. You figure out what the weed is, make sure it's what you think it is, And then your second step is some sort of herbicide. So going in with some sort of agent inside the bladder to try to prevent those weeds from coming back. And that's how, I explain it to patients. I think it's a helpful analogy. I will say we have some newer agents, which we'll talk about later, that potentially can act as a non-surgical tumor destruction that I think we'll be looking for in the future. But that's at least kind of the lay of the land that I tell patients. And then, we do periodic cystoscopies to look in and see if anything has come back. But really the goal of the intravesical treatments is to keep things from coming back that we've cleaned up during surgery.
Yeah, I love that analogy. I may steal that, and I'm sure others who are listening would too.
Yeah, we got to credit Dr. Hafez with that one. He's the one who came up with that.
That's awesome. Okay, so this is a patient with a small high-grade tumor. What influences your decision to either observe or to do something? Let's start there.
A lot of this is going to depend on kind of what the patient is looking like to you and what their risk tolerance is. But for high-grade disease, I generally recommend some form of intravesical treatment. In my mind, I think it's easier to break it up. And in practice, what I feel like has worked for my patients is high-grade tumors tend to respond a little bit better to immune agents like BCG. Low-grade tumors tend to respond a little bit better to intravesical chemo. So chemotherapeutic agents such as gemcitabine-releasing. And so that's kind of where I start. And so for this patient, if I had BCG available, that would usually be my first line of treatment that I would offer.
Got it. And if you didn't, then I assume you'd move to the gemcitabine like you alluded to. That may be a better option for low grade.
And oftentimes if it's, high grade, if it's on the higher volume side technically, multifocal is not an intermediate risk, you start to get into the high risk category. But if BCG is not available, then generally I tend to lean towards gemdosi if it's high grade disease. If it's a smaller, really small volume, then maybe I can be swayed to use single agent. But, we'll talk about some newer agents later that are coming through. But in general, if BCG is unavailable, we've been relying on gemcitabine docetaxel.
Yeah. And who do you surveil? And what's that conversation like?
I essentially do surveillance on almost everyone. It's a very patient-centered discussion, though, I think. Most patients want some sort of look back in given the known risk of recurrence. If they have lower grade disease, if they've gone, in non-multifocal disease, I think those folks can go a longer stretch between in-office cystoscopies. If it is somebody who has higher grade disease, I tend to lean a little bit more towards seeing them every 3 to 4 months. Low grade disease, I think you can space out to 6 months pretty quickly.
Got it. Let's say it's either high grade or low grade and you're not doing any intravesical therapy. Maybe it's the patient has really bad lower urinary tract symptoms. They can't hold the agent. Maybe they just live really far away and it's not feasible for them. I know you and I both practice in areas where distance is an issue. We have quite
Absolutely.
Rural populations. What does that conversation look like? How hard do you push them? I think that's a big challenge for us because a lot of times patients will ask, do I really need this? And I think in this space, the answer is not as straightforward as BCG for high-risk disease.
Yeah, I tend to agree with you that it can be challenging. Again, it's, leaning on patients to see what they're able and willing to do. For folks who are not wanting to do any sort of intravesical treatments, then oftentimes I keep a slightly closer eye on them during surveillance just to make sure. I always counsel people if you have any blood in the urine, I always want to know about it right away. I should be the first phone call outside of your spouse. I think that's helpful just to kind of set some expectations of when they should call you. But for those folks, I generally don't push super hard unless it is, for low-grade disease, I don't push super hard unless it is multifocal disease. Those folks, I feel like, have some sort of abnormality within their urothelium that is, causing things to have multiple sites that pop up. Similarly, when it's recurrent disease, that's when I push people a little bit more. So if they had a, 3.5 centimeter tumor that you resected, you gave peri-op, gemcitabine, and they're like, Doc, I can't make it here. Then those folks I offer, this is what the standard of care is. This is what our guidelines recommend. But if they don't, I don't push for it too hard. If they've come back and they've had multiple recurrences and I'm on we've already gone through one agent and they have a bunch more tumors popping up, then those are the folks who I really try to encourage them to get some sustained intravesical treatments just to get that cytotoxic effect. The other thing I always have to keep in the back of my mind with these folks with recurrent disease or multifocal is just making sure you evaluate their upper tracts, make sure you get a CTU so that they don't have something that's shutting down, because when things are behaving a little bit abnormally, you just want to, dot your I's and cross your T's.
Yeah, that's a great point. Definitely an important thing to remember. So, BCG, gemcitabine, BCG obviously can be a challenge at times. I recently read a new update from Merck that they're working on the plant, so that's great.
We're like 4 years into still working on the plant.
Yeah.
I'm like, any day now.
Yeah. But let's talk about some of the newer agents. Again, I think the majority of them are generally discussed in relation to high-grade disease, but I'm aware that certain populations in specific trials did include intermediate risk patients, and there are drugs that are specifically for the intermediate risk space. So, wondering if you could give me a little bit of the lay of the land, and I'd love your comments there.
Yeah, there are a couple of new ones all at varying stages of FDA consideration. I think the first thing we tend to rely on is gemdosi just because it's easy for us and that's FDA approved, easy to get, it's relatively cheap. When we start to get into some of the newer agents that are up at the FDA right now, there are things like Anktiva, so that's the IL-15 superagonist, and 803 that we're looking at. That was studied under QUILT. This group is a little bit hard to interpret kind of some of their early data, but they were FDA approved in April of 2024 for BCG unresponsive disease. So kind of next step is looking into some of these folks who haven't had BCG. From the data, it looks like that agent is going to be most effective in folks who have high-grade disease in combination with the Anktiva plus BCG. So one struggle with a lot of these is they still rely on some form of a stable BCG supply. So I think that's been a bit of a struggle. But so I think that one's out there. I think there'll be more data coming out. I know there are a couple of different trials looking at it in the BCG naive space of high grade TA. So I think that'll be an important one to look at. Another one that's been just had a new drug application submitted to the FDA that we should hear an impending decision in June is the UGN 102, which is a gel form of mitomycin. And that one is more specifically for low-grade disease, and that gel form should help it have longer contact time with the urothelium. A larger study of about 240 patients looked at that, 6 weekly installations. It's given through a catheter, so the same way that we typically give, so that makes life a little bit easier than some newfangled way of giving the agent. But 80% complete response rate at 3 months. And of those folks who responded at 12 months, 82% of those were still disease-free. So that's really promising. And that's in folks who have some untreated small low-grade disease. So this is an agent that looks like it maybe can do some of the job of cleaning up some of those little things that you may see when you're doing your surveillance cystoscopy. You might be able to eradicate those without having to go in and surgically remove them, which would be ideal, really.
Yeah. I mean, I think that's a great point with the UGN drug because it, we don't think about this enough, but it's actually chemoablative. And so it's obviating the need to go to the operating room, which is obviously convenient for the patient. But I think in some of our patients, like these patients can be pretty old. They can be pretty frail. I know we talk about TURBT like it's an in and out thing, but for some of these people, it is not.
Yeah, and some of these folks are on blood thinners and trying to get them off of those and get them back on for surgery. I mean, that to me is a huge win. I feel like so many people with bladder cancer are on Eliquis and Xarelto and trying to bridge them on and off in the safety profile of doing some of that stuff. And this is a really nice option. A lot of times because they're on those agents, it's not super easy to ablate them in clinic or fulgurate them in clinic. So if you have a drug like this, it's really a nice thing that you can offer your patients.
Yeah, I agree. And it's interesting that it is also one of the few areas where we've had dedicated trials in the intermediate risk space.
Absolutely.
So I think that either way, it adds to our understanding and our confidence to arm us with these discussions when we're in clinic, when we're talking to patients, and just have a better understanding of the disease process in general.
Yeah. And I think too, it's, some of these newer agents as they come online, using them sensibly, like this thing isn't going to get rid of a 5-centimeter low-grade tumor. It's just not. But for those folks who you see who have these tiny little smattering of a couple millimeter recurrences, like this is a really great, opportunity to treat somebody in that space in a much less invasive manner.
Yeah. And, again, we talk about TURBT. I think in most cases it goes really well, but sometimes there are those challenging locations, there's challenging bladders, and so it's good to have that option. Okay, so we talked about 2 agents. I think
There's more.
there's more.
But wait, there's more. Yeah, so a couple of the other ones, I think, we've all been a little bit enamored with the gemcitabine pretzel, the TAR-200 agent. That one's it's such a neat delivery device. And so they've looked a little bit, most of the work, and that's from the Sunrise trial, has been done in the BCG unresponsive space. There are ongoing trials to look at, what kind of role would this have? And to me, this is the ideal group because this is the people who are already low-grade disease, is the people who are already giving gemcitabine to. So this to me is hopefully good data will come out of here and we can kind of get this one up and running. Practically, it's exchanged every 3 weeks during treatment. And so, that's a nice, less time-consuming option for patients where they can get a sustained exposure to the drug without having quite so many visits. I know our patients are coming from far away frequently, and so getting this and having them tolerate it would be really helpful. So
yeah,
I think
absolutely.
This one's also pending FDA review. So there's a couple of things that are at the FDA right now that have had new drug applications submitted, and it's just a matter of kind of watching it go through that process. But we're eagerly awaiting some of those.
Yeah. And I think the interesting thing about this device specifically is it's a drug that we have understanding and experience with. And so although it's a new delivery system, that delivery system is important for convenience, as you alluded to. But at least we can talk to our patients about the fact that it's a drug that we know it's tried and tested. There's ongoing trials more in the gemcitabine versus BCG space, of course. But when we're talking about low-grade disease, we have experience to lean on.
Yeah. And so it's helpful to have that data and we can talk to patients about it. We know it works. And so, yeah, I think it's this to me is an ideal spot for this agent.
Yeah. It seems like there's a flurry of agents, obviously, as it relates to intermediate risk, also high risk. It can get really confusing. It's, for those of us who even are urologic oncology trained, I think it's going to be challenging to figure out who is appropriate for which agent. So I'm just curious, for your thoughts in general. I know we're still waiting on approval for some of these drugs, but as you think about the overview we just discussed, what's sort of the triage mechanism in your head, and maybe different considerations from a quality of life perspective that we can use to make these decisions with our patients?
Yeah, I think thinking through what people can logistically get is probably the most important. I'm always a little bit surprised by how patients do with some of these drugs that we give. I mean, you have people who have just terrible lower urinary tract symptoms, and I think sometimes it's from the cancer. I had a gentleman who had a lot of high-grade TA disease and a lot of CIS, and we, so not intermediate risk population, but he got treated with BCG, and finally, towards the end of BCG, he actually, I think, had some control of his disease and started feeling a lot better. And his lower urinary tract symptoms actually improved on BCG, which is not something we frequently hear. I'm like, okay, well, that makes me feel like this was probably the cancer causing your lower urinary tract symptoms. But so I think some of those considerations, in my mind, I think that a lot of the lower grade tumors tend to respond a little bit better to the chemotherapy agents, and the higher grade tumors seem to respond a little bit better to some of the more immune-mediated treatments. And I think we see that a fair bit with the data when we look at, some of the folks who have the best responses are people with CIS. It's very effective. And so it makes me think that, there's some mechanism there of why that occurs. And so I rely heavily on pathology and what I see at the time of, cysto and TURBT. And I tell patients too that, we're going to try this one thing. And if it doesn't work, we have a lot of things in our toolbox to try next. And just because you have a terrible reaction to one thing doesn't mean that we have to take your bladder out. We can try something different. I think that they need that reassurance because it's a lot for them to go through. And I do keep cystectomy in the back of my mind, less so for low-grade patients. I would hate to take a bladder out in a patient with low-grade disease. But eventually you sit back and you look at this, and if they've gotten, induction BCG, all the surveillance, any form of maintenance, and then you give them induction, something else, it's another, 6 weeks, and they've been in your office, a lot, and driving back and forth and taking time off work. So I try to be cognizant of just, keeping keeping things on the table, letting them know that there's hope with some of these other agents that we can try. I also feel like a lot of patients think, oh gosh, I was totally tortured by BCG. It must have worked. And I'm like, nope, like how you tolerate it doesn't at all correlate, unfortunately, with whether you responded to it or not. So I think just being open and honest with them. But I think about what it's like for them to come for treatments, because it can be time consuming. So for folks who are really far away, something where you can do it once every 3 weeks, that offers a better quality of life for people who are driving far distances. We try to partner with people in the community to see if we can get folks BCG and other agents. Some cancer centers and infusion centers are really willing to help with some of our gemcitabine docetaxel delivery. I know there's a bunch of folks looking at kind of in-home, like home health nursing, basically administering BCG, some of the newer agents, UGN-102 is one of them, and just seeing the feasibility of that. And people are like, they're able to do it. So I think, there's a lot on the horizon with trying to find new delivery methods in addition to new delivery systems that are a lot more convenient for patients.
Yeah, absolutely. I mean, I know you know this better than most of us, but there's such a shortage of urologists, particularly in rural America. So figuring out novel ways to get patients in-home treatments, it's going to be really, really important. I'm reflecting on what you said about the symptoms patients have, and it reminds me of a patient I saw on Monday who said to me, we were trying to come up with a game plan. It's already failed multiple intravesical agents, and we were having that discussion about cystectomy versus a last-ditch attempt at a trial of intravesical therapy. And he said, well, you know what? The one good thing about surgery would be I can actually sleep at night. And so we underestimate it because we're getting one slice of their story for 20 minutes in clinic, but I mean, it's every night for him, and I think that's really important. So that leads me to my question. For all of these agents and for patients who are getting surveillance cystos, for patients who have intermediate risk disease, the cancer itself may be causing lower urinary tract symptoms like you alluded to. How do you manage this? I mean, it's a simple question, and it's funny because it's like general urology. You think we go straight to anticholinergics, but it's not always that simple. And it's not always that simple in this patient population. So tell me your thoughts.
Yeah, you're absolutely right. There are a lot of people who really have a ton of side effects. And there are people who, and we've all seen them, who have gone through several rounds of treatment and either get a defunctionalized bladder or they're just so challenged by, decreased bladder volume, having to wake up all the time and go pee, and it ruins their life. It's misery. Like having to get up to pee every 30 minutes. They can't even make it to your office, right? Like they can't hold the drug. And so there are folks like that, we try everything we can. We do try anticholinergics. We try, for just the simple trying to get them in office to hold the drug. You can try clamps. We can leave a catheter and try to do that just for the in-office procedure time. But a lot of those people they're really struggling. I do kind of the good old urology, like get them on a bowel regimen, make sure that like there's nothing else going on, like we all learned from our peds urology days. Get them on Flomax. I've had some people have good responses to Myrbetriq. Some of the folks that have treatment related, so either from mitomycin, gemcitabine, BCG, changes in their urinary habits, they do get better over time. I've seen a lot of people, the further out we get, the more normal their bladder looks and the greater volumes they're able to hold. They can make it to appointments and things like that. And so trying to at least tell them, hey, I think we're going to be able to get through this. We just got to give it time. But also being there, listening to them, making sure they don't have, a UTI, sending them for, cytology, make sure you're not missing anything again. All of those things I keep in mind because you also don't want to brush them off because they are having a lot of symptoms and it's a tough time for them and their families too.
Another thing I've been doing in my women patients specifically is vaginal estrogen. I'm like
100%.
really quick to jump on that.
Because it's that patient population. It's like these, oftentimes ladies who are a little bit older who are postmenopausal. And, I think that is 100% the right thing to do.
Yeah, absolutely. Even if they're not having UTIs, I'm like, just try this. I think, and I've always heard, oh, I feel so much better. I didn't even know I needed this.
Yeah,
so that's great.
It's be patient. It takes a long time to work, but yeah, I think getting folks started on that, as you know, there's low cost solutions for that too. There are drugs that are available at a much cheaper through the cost plus drug program and various other resources. So it's not as much of a financial barrier as it used to be.
Yeah. Well, that's a perfect segue into my next question. We covered all these agents. Obviously, the agents that we have relied on for years tend to be cheaper, tend to be easier, but we have a lot on the horizon. What are you thinking about from a cost perspective, both for the patients individually, but also for the health system in general?
Absolutely. I think this is a big challenge. In part, I try to start with low-cost solutions, right? We start with the BCG, with the gemcitabine docetaxel, mitomycin, things that, tend to be less expensive as we kind of escalate in care, particularly for folks in the BCG unresponsive space who may be very disinterested in talking about cystectomy. I do start to evaluate them for some of the other agents. They are wildly expensive, and it's hard because there's probably access issues for our patients. So I think, working with the pharmaceutical companies to see what we can do to get people lower cost drugs, but it's challenging. And I think for the health system as a whole, eventually we'll get to a point where these can't be, at this cost, they can't be frontline agents that we're using. They have to be something that we're kind of reserving for, later stages of the disease in terms of we've failed some of the lower cost options, because there are a lot of people who are well treated and cured by BCG, cytidine docetaxel. So those are, upfront the ones that we should be using. They have a fairly good side effect profile as well. Nothing that is coming out seems to have a better disease control or side effect profile than what we currently have. So I have to keep that in the back of my mind so that we're, use what we have. But I'm super grateful, and patients are incredibly grateful to be able to keep their bladders and, not have intense treatments with these newer agents that are available.
Yeah, absolutely. I mean, I think you reframed it really well as we think about some of those historical agents, keeping those first line for now, given the cost considerations, I think are important. A big challenge is obviously access to those drugs. So the shortages, I think, really, really are what create a frustrating situation. And, again, going back to the fact that for intermediate risk, there's really only one drug that sole purpose we've talked about is to solve that problem. I think it's going to be a game changer for patients who are higher risk, not from a cancer perspective, from a comorbidity perspective.
Absolutely.
I do worry, like we talked about, I do worry about cost. I do worry about that. But I think we'll just have to wait and see how it plays out.
Yep. I think, patients will tell us and guide us, and we'll be here to listen.
Yeah. As we start to wrap up here, we talked about new agents. We talked a little bit about counseling and symptom management and all of that. But what else do you think needs to be done? What can we do as a field to better understand this intermediate risk space? Because again, I think patients who live in it a lot of times are transient in that hopefully we can get them to a cure and, we're really monitoring for recurrence. But oftentimes, those high-grade patients, when they do recur, they'll jump straight to high risk. So I think there's this little niche of intermediate risk. You alluded to this. It's an annoyance. How, what's missing? Because patients will ask me that in clinic all the time. They're like, what is this space? I look online, all I see are low grade and high grade. And to be honest, I'll start with my answer to this question. Some of it is standardizing the guidelines. That's really frustrating. The fact that the guidelines define this as a different space depending on, which society you're looking at. So curious about your thoughts there.
Yeah. And I think too, I would totally agree. Any standardization that we can do in terms of both guidelines and then outcome measurement, trial development, we all need to be speaking the same language. Right now, in part because of some of the BCG related shortage issues, FDA guidelines around outcomes, we have a lot of single arm trials. And those make it super hard to do head-to-head comparisons. And then if our head-to-head comparison is against BCG, like the Bridge trial, and then we run into problems with supply. But so I think we do need to keep kind of speaking the same language so that patients understand kind of, fair comparisons of these drugs and what their potential benefit is. I think one of the challenges in the intermediate risk space is it is a hodgepodge. And so it's trying to figure out what is their overall trajectory. We kind of have a moment in time. And so I think that's what creates a little bit of heterogeneity in that group is you have some people who are recurring that land them in the intermediate risk group. And those people are behaving differently than the folks who are a one-time, I had a 5 millimeter high-grade tumor. And we've had those, everyone has had those people that you resect and they're like, I don't want to do anything. And they never recur. And you're like, I don't understand, but okay. And so I think trying to figure out kind of their overall disease trajectory, I think at the end of the day, a lot of this comes down to disease biology, and then you overlay that on patient factors. And so better knowing more about the disease biology, like why is low grade the way it is? Why is high grade the way it is? Why does some low grade grow to 5 centimeters and not seed the bladder all over? And then some of it is tiny little 5 millimeters all over. So what is some of the kind of molecular basis of why that's happening? And can that help guide us further with treatments? Right now, we're pretty... I mean, if you even think about the way we talk about, grade, it's like low grade or high grade. We don't have a detailed definition. I tell people, like, we put this in 2 buckets. And so I think that that's understanding more about why things are the way they are from a genetic and a molecular component, and then trying to see what their overall disease trajectory. I think a lot of what we end up doing is kind of buying time to see how things are going to play out. And then we start kind of layering on our interventions and see how people respond.
Yeah. And I know that there's ongoing work to better understand this disease and the difference between low grade and high grade from a molecular perspective. The one thing that I'm looking forward to is learning how biomarkers can help play a role here, something we didn't really talk about. But I think potentially, you see a patient with intermediate risk disease, hopefully there'll be a biomarker that can help stratify who we can watch, who we can potentially try maybe something like gemcitabine and not waste our BCG here, or who needs a more expensive option. So, is that what you're looking towards too?
Yeah, because I think right now so many of us rely on cytology, and cytology particularly for low-grade disease is like very unhelpful. I oftentimes don't even send it in a low-grade patient because now our cytology reports often come back here as just negative for high-grade urothelial cells. So if I know I'm in a low-grade patient, what am I doing even sending this test? So I think that better biomarkers, better way of understanding it, incorporating better technology when we're doing cystoscopy. So, what is the role of some of these other agents like blue light and things like that, of making sure that we're eradicating disease and keeping it under control. But yeah, I think this area is ripe. A lot of the activity has been in the BCG unresponsive space for a variety of reasons, both BCG shortage and that's been just an area ripe with new agents and trial development. But the low-grade space, I think, is actually, from a population standpoint, much more impactful for patients because so many more people have it. So...
Yeah. And the last thing I'll touch on that I can't end this podcast without mentioning is the importance of smoking cessation. I think it's another point that we got to make, particularly in this 100%. Disease. It's like you guys are at high risk of recurrence. This is the one modifiable thing we can do today to try to prevent that.
Yeah. And I think we've all had those folks sit in front of us and say, what can I do to stop this, nuisance low-grade disease from coming back? And I'm like, quit smoking. And so absolutely, that's on us to talk about every patient, every time. We see them a lot. Frequently, we're the only people who see them for months and months and months. And so we really do have an opportunity in reminding ourselves of let's control some of those modifiable risk factors.
Yeah. What is the protocol that you have at your institution? I mean, we're lucky in that we now also have a dedicated smoking cessation team. So I counsel the patient and I'm able to make that referral, and they are really good about providing the patients with appropriate resources. If they're having trouble with patches or, other forms of nicotine, they're able to suggest more intensive medication regimens, et cetera.
Yeah, we have something similar. We have a clinic we can refer to. It's part of our intake process now as well. So our medical assistants will screen for tobacco use on intake at every visit. So eventually the patients, I feel like, get a little bit badgered. And so if the medical assistants identify that they're smoking, they'll ask them if they're interested in smoking cessation. And then I usually follow up similarly. The other thing I think is really important for these patients is I talk to their whole family about smoking cessation, whoever's with them, because it is really hard to do when, your spouse is out smoking and continues to smoke. Just like dietary changes, it's the more folks you can get kind of making that change together, the easier it is on the whole group.
Yeah, absolutely. Well, thanks for taking the time to chat with us.
Thank you.
I really appreciated. Any final thoughts for the audience here?
No. So, this is a ripe space. I think keep taking great care of these patients. They appreciate everything we do and all the advances that we make. So it's a continually evolving field. So it's hard to keep track of it, but I know you guys at BackTable here are continually working to get folks on to talk about what's new and what's coming. And hopefully after the FDA meets over the next few months, we'll have a few of these newer agents available that we can get out into practice.
Yeah, absolutely. Thanks again for joining us. And to our audience, thank you so much for tuning in. Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.